Hello and happy Valentine's Day. We're all here because we love animals. So what a great day to learn about how point-of-care ultrasound can improve their care. I'm Jeunesse Gaston-Gay, VP at Clarius. I'd like to welcome you to today's live educational webinar with renowned experts, Dr. Soren Boysen and Dr. Serge Chalhoub. Today's topic is Veterinary POCUS, diagnosing canine pericardial effusion in seconds. Although physical examination and radiographs are helpful, ultrasound is considered the reference standard. Doctors Boysen and Chalhoub will share their POCUS best practices for differentiating pleural from pericardial effusion to make a timely, confident diagnosis when your patients are agonal and seconds count. Before we start, I'd like to thank the Vet Show and NAVC for inviting you all to join us here today. You're among 3,100 doctors of veterinary medicine who registered for today's popular educational event. This webinar is race approved thanks to the Vet Show, so please do stay on for the full session to qualify for 1 CE CPD credit. By participating for 50 minutes or longer, you'll receive an email from the Vet Show in the coming week to redeem your educational credit. After the main presentation, we'll see live scanning with sonographer Shelley Gunther and our furry supporting character, Mabel. At any time during this webinar, you can use the Q&A box. Doctors Boysen and Chalhoub will be available to answer questions during the live Q&A session following the presentations. Let me now introduce you to your host. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Hi, Dr. Frankel.
Hi, Jeunesse. Good to be back. To set the stage for today's talk, we did a bit of a literature review, trying to focus more on the topic at hand. And the first paper I wanted to review was really talking about training and skill acquisition. In a lot of webinars, we get a lot of concern from early on providers who are new to point-of-care ultrasound, wondering how they can acquire skills to both generate the images and interpret them. And I wanted to highlight this review of research that really supported how it's really within reach of anyone with the motivation to learn. In this study, taking a set of house officers who are really junior learners and just subjecting them to some basic didactic skills and hands-on learning, they were able to acquire really adequate focused echocardiographic skills in a short amount of time, meaning it's really within reach of anyone with similar training. The next paper I wanted to talk about was kind of focusing more on cardiac scanning, specifically on pericardial effusions, which is appropriate to today's topic. And in this observational cohort that went over almost 20 years, echocardiography was seen to be highly sensitive and specific for the diagnosis and differentiation of pericardial effusions, but also of the right atrial and heart-based masses that might be associated with them, really helping to narrow in a diagnosis and effectively introduce a treatment plan. And lastly, was something we've talked about before in the fast exams in the veterinary population, that some of the approaches are really similar to humans that we take, that digging deeper into how to approach a pericardial effusion, in this retrospective observational cohort, they found that the diaphragmatico-hepatic window really adds clinically relevant and useful information to the focused abdominal assessment scans, specifically for pericardial effusion, and so should be included when teaching or learning the different views to identify pericardial effusion and part of everybody's routine. And before we get into the nitty-gritty about how to do that more, we wanted to put up a quick poll to you. We know we have learners from across the world in different walks of practice and at different stages of use of point-of-care ultrasound. And so how frequently do you use ultrasound to attempt to diagnose a pericardial effusion? Are you just learning today, or is this something you do rarely, monthly, or even in your daily practice if you're in the critical care or emergency world? We'll give this a quick second and then close it out. And let's see. Okay, so we're across the board. We have a lot of people, about a third just learning today, maybe a third in the middle, and then a third are doing this great. So, what's excellent is that our guest speakers have something to share with everyone, from beginner to expert. And it's really our honor to introduce Dr. Soren Boysen and Serge Chalhoub again from the University of Calgary Faculty of Veterinary Medicine. Dr. Boysen is a specialist in veterinary emergency and critical care, while Dr. Chalhoub is a specialist of veterinary internal medicine, small animals. They're both recipients of numerous teaching and speaking awards and considered pioneers in veterinary point-of-care ultrasound, having introduced the veterinary profession to the FAST exam through the original study published in 2004, and having a combined total of over 25 peer-reviewed articles and book chapters on the subject. Doctors Chalhoub and Boysen, I'm going to hand it over to you.
Hello, everyone. I'm Serge.
And I'm Soren.
And we're very happy to be here today, Dr. Boysen. What are we going to be talking about today?
So this is a great topic for Valentine's Day. We're looking at the heart. And hopefully we're not going to break any hearts today. We're going to just present Pericardial Effusion, Diagnosis in Seconds, because point-of-care ultrasound is really, really vital when it comes to helping us identify and treat patients with pericardial effusion.
So hold on, you're telling me it's Valentine's Day and we're going to be talking about matters of the heart.
This is true. There you go.
All right.
So just a quick caveat that in relation to this presentation, both Dr. Chalhoub and I do teach point-of-care ultrasound at the University of Calgary, and we do receive honorariums for conference lectures as well, but otherwise we have no conflicts of interest to declare.
Do you think that it's odd we're together for Valentine's Day?
I think it's very odd.
I do too as well. Yeah.
Not so odd. Not so odd.
Didn't Oran say we need some
But thank you for joining us, for all of you out there that join us for this Valentine's Day lecture.
All right. Well, without further ado, let's go dive right into a case. So what do we have, Dr. Boysen?
So this is Shira, and we'll just go through the initial history and triage. It's a 10-year-old female Labrador Retriever. So don't get any biases or preconceptions on what we're dealing with. It's a 10-year-old Labrador Retriever, vomited 24 hours ago, lethargic and not eating the past 24 hours. The presentation, this is the kicker, suddenly collapsed while in the backyard about 20 minutes prior to presentation.
Yeah, that's a little concerning. So I'm assuming at this point we should do a triage physical exam.
That would be a very appropriate place to start. So we did do our triage exam. You can see we're tachycardic at 176. The temperature, 98.2 Fahrenheit or 36.8 Celsius.
Yeah.
So we are hypothermic as well. Temperature's low. And we got pale mucous membranes, prolonged capillary time.
Sir, I'm a little worried about what's going on over here.
Okay, so I was going to say, based on this, you got weak pulses and your abdominal patient's unremarkable. So what are your thoughts, Dr. Chalhoub? But don't say run away. What are your thoughts at this point in the initial assessment or triage?
Well, at this point, I would have run away. I mean, that's a little scary at this point. It's not the kidneys.
All right. Let's make it a little simpler for you.
Hold on.
Stable or unstable?
The patient is unstable.
All right. So we got an unstable 10-year-old golden that comes in or a retriever that comes in. What are your thoughts, your general overview of why could this patient collapse at this point in time?
Well, I know you didn't want us to think about it, but it is a 10-year-old Labrador. I got to be worried about hemoabdomen, right? I mean, we're thinking about splenic hemangiosarcoma, probably one of the top things on there.
Absolutely.
Yeah.
And again, then, since you're the internal medicine specialist, I'm going to ask you for a few more differentials, if you'd be so kind, for the collapsed dog that presents in shock.
Well, we could think about a heart problem. So, of course, we have potentially arrhythmias. That could be another thing. Hemorrhage somewhere else. That is possible, right?
Yes, indeed. Because we got hemorrhage into the abdomen from the liver or from the spleen, but we could have hemorrhage elsewhere. We could have neoplasia elsewhere causing that, for sure.
Yep. If this dog was not 10 years old and potentially 3 years old, we would have been thinking about Addison's disease. Now, that's a cool disease.
Indeed. Atypical Addison's or Addison's with full-blown shock. We can see that. It does typical, like you said, the female 2 to 3 year old, but we have seen a few atypical cases due to other causes. What else?
Well, if we lived in New Orleans, I know they have mean insects there, and potentially that can cause anaphylaxis.
Correct. So we don't seem to see that often here, but that is on the list for collapse, sudden deterioration of our patient. Pericardial effusion, since we missed that in your list of differentials, and maybe just a hint with the topic today, we'll throw that one in there as well.
Seizures, certainly possible. I've seen patients that vomit, and potentially have a vasovagal event, and they collapse from that. So that is also possible.
And we could have, although it's usually a more insidious onset, we did have the vomiting collapse possibility that maybe we had a sudden GI rupture and we got a septic abdomen.
So yeah, I wanted to say pericardial effusion last there, Dr. Boysen, because again, that is the title of our talk. But I got to say, I'm still coming up with the same option here. Ask the criticalist, run away.
All right. So let's break this down and do this one step at a time. What do you want to do next, my friend?
Besides running away?
Besides running away. As you're running away, what would you like to yell and ask for that gets done with our patient?
Well, at this stage, you always yell at me when I recommend a rectal exam, which I do think is important. I think we should do a minimum emergency database, probably get a PCV, right? Probably get a lactate, a glucose, maybe find out if the patient is azotemic, get a blood pressure. I think that's a good start.
Exactly. We're going to do a minimum emergency database. What are we going to do with our minimum emergency database? You're absolutely correct. We got a pack cell volume of 46, total solids of 60 or 6.0. Lactate 6.7. What are you thinking?
That seems really high.
Okay, that is high. And why do you think that lactate is high, given this particular history and our findings?
Well, I'm assuming that this patient is in some kind of poor perfusion shock, Dr. Boysen. We're unstable.
Well done. Well done, my friend. I can see that working those ER shifts on the weekend is doing you some good. Our glucose, it's actually a little bit elevated, but probably due to stress, not too concerning. Our azosticks, which gives us a rough estimate of urea, that's okay as well. And Doppler blood pressure, you happy with that?
No, I mean, as a grade, that would have been great, 85%. I would have been happy with that, but 85% of systolic blood pressure, I think that makes me a little nervous.
All right, millimeters of mercury, not really a percentage, but okay, 85 millimeters of mercury. I agree. It's lower than 90. That's kind of our cutoff. So not surprising with these results, given our initial presentation and clinical findings.
Well, hold on. This does help me narrow the possibilities. I don't think this patient is bleeding, right? So I don't think we have a hemoabdomen. Sepsis makes a little less sense. I mean, I know the glucose isn't that sensitive per se, but, being this sick, I would assume he would have been hypoglycemic, had some other signs of sepsis. What else can we eliminate?
All right, and then we'll look into anaphylaxis. I wouldn't say it's impossible based on what we're seeing so far. We'll probably need to do some more evaluation. So anaphylaxis is still on our list for sure.
Yeah.
Hypovolemia, I mean, that's, again, usually going to be a bit more insidious. And then we've got pericardial effusion. We're thinking pericardial effusion. You said, well, I don't think he's got a hemoabdomen because it's usually more blood loss that results in that shock. And we usually see a more definitive change in that total solids, at least, if not the pack cell volume. So I would agree with you. And pericardial effusion, though it's a smaller bleed, usually probably won't affect the PCV total solids, but certainly could cause these signs. Agreed.
So we had heart a couple times on there, different things, arrhythmias. One thing we do like to do on triage is look up an ECG. I think sometimes that can really help us.
And this is the ECG recording here. What do you think, other than the fact it is tachycardic? Are you worried at all? Do you see anything concerning with this particular ECG pattern?
I'm worried I'm seeing doubles here, a little bit here and there, like one's big, one's small, one's big, one's small. Is that just my imagination?
No, that's a very nice observation. It's alternating between the amplitude of the QRS complex. That is electrical alternans, my friend.
So should we spend the next hour talking about ECG changes, or what are we here to talk about?
Okay, so the thing that I would like to point out is you've gathered a lot of information.
Yes.
You've narrowed your differentials. You've done a nice job of ruling them in and ruling them out.
Thank you.
Where do we start now that we see electrical alternans? What is it that usually, not pathognomonic, but almost always causes electrical alternans?
Well, I got to say, I know this one, even though you are the one who taught me 15 years ago. I know this. This is going to be pericardial effusion.
That is correct. So in that case, then, you've got this findings. It's directed you. What is the question you want to answer? Pericardial effusion. Nicely done, because we want to use that initial history and physical exam findings, put everything together to say this is the most likely cause. Bayes' theorem, pretest probabilities. I want to go looking for pericardial effusion.
So
well done.
We're not starting with the kidneys. We are starting with the heart.
Yes, especially given the patient's unstable and might die.
The kidneys can do that, but you're right. They're more resilient than the heart. So when it comes to pericardial effusion, what are we going to be talking about today?
All right, so we're going to go through causes in dogs, which is the very common thing that most people think of with pericardial effusion, but we'll touch base on cats as well.
Yeah, so we're going to do clinical findings and diagnostic tests, which we've already kind of covered.
And then we're going to talk about using point-of-care ultrasound, what windows we can use to assess our patients to see if they have pericardial effusion, and then also in that same window or in those windows, how we can differentiate pericardial from pleural effusion, because that's not always that easy to do.
We're going to talk about tamponade. We're going to talk about what tamponade means and also what potentially will look like on ultrasound.
Indeed. And then we'll come back to, since we've got the diagnosis, we'll touch briefly on that. It's not really the focus of the talk. We're going to talk about emergent stabilization. And I will point out, this talk has nothing to do with the kidneys.
That was really mean.
We'll come back to the kidneys in future talks.
Unnecessary.
Okay. We're coming back to it.
Unnecessary. The
coming
kidneys
back to it.
Are hurting right now from poor perfusion.
Kidneys are always hurting.
Jeez Louise. All right. So let's talk about causes of pericardial effusion in cats and dogs. So we know that it is very rare in cats. I feel like the only time I see it is specifically when they have heart disease. We're going to talk about that. But what about dogs?
All right. And dogs, most of us are familiar with this as well. There's two big causes. We've got our hemangiosarcoma and we've got our idiopathic. Within that heart-based tumors and hemangiosarcoma, so we got two big neoplasias, hemangiosarcoma, which is usually in the right atrium, and heart-based tumors, chemodectoma, mesothelioma. Those make up one big group, and the other is idiopathic. So those are our two big groups, neoplasia and idiopathic.
And I got to say, idiopathic, you're always worried about that grain of salt, right? That you're worried that a couple months later, boom, you actually have that neoplasia you can diagnose, right? So we got to be careful about that category. Other things, we have coagulopathies, we have left atrial rupture. I know you like that one as an emergency. Man, does that freak me out when I see that.
That's an interesting one, and we're going to come back to that because it doesn't always show up as our classic pericardial effusions. On top of that, we got infectious, and then we've got occasional mild with cardiomyopathies. We don't see that as commonly in our canine patients, but they may get a little mild pericardial effusion that's not causing a problem, and it's secondary, incidental to the underlying cardiomyopathy.
Yeah, exactly. And there's even a study on this.
Indeed, there is. And when it comes to cats, then let's talk about cats before we go back to that. This comes to cats. We've got lots of different causes.
Yeah. Most
Most people don't think of pericardial effusion with cats.
Correct.
Here is an interesting retrospective study with 146 cats.
Wow.
So don't automatically rule it out. And if I said to you, what's the most common cause in cat for pericardial effusion?
It's going to be HCM, and it's usually non-clinical. In other words, it doesn't affect the heart function and the patient doesn't feel it. But yeah, sometimes you can see it with HCM, but I have seen it with lymphoma as well.
Exactly. So more than 80 to 85% of our patients, if you really look at the literature of some of the more recent work that came out, are going to be associated with heart failure.
Yeah.
Other ones, though, like you said, Leophages in there. We got idiopathic in cats, too. So sometimes we might see an idiopathic.
Yeah.
We've got uremia versus fluid overload. Like we got thyrotoxic cardiomyopathy. So there are some others. Don't automatically always assume it's going to be the heart. The odds are it definitely is. But keep in mind a few of those other zebras at the back of your mind that may also contribute to pericardial effusion in cats.
But usually non-clinical. Compared to our dogs, often, I think the situation we most think about is that dog coming in with the acute onset of pericardial effusion. That pericardium doesn't have time to stretch, right? And that patient collapses. That's kind of the classic.
Yes, and those are the ER doctors. Those are the ones that we see that are coming in, crashing and burning. They're collapsed. They're in the states of shock. They might even be agonal. So those are acute onsets for sure. And what else will we see in those acute onsets that will sometimes push us in a direction maybe to think of pericardial effusion?
Yeah, well, you know what? Sometimes they will come in for GI symptoms, right? We might see them with vomiting as one of the first symptoms. What? Explain that one to me.
Yeah, I'd say basically that stretch of the pericardium. You stretch any visceral lining or serosal surface, you can potentially activate chemoreceptors, and you can activate that vomiting with that stretch receptor. And that actually, in this case here, you can see 51% of dogs with identified pericardial effusion had a history of recent vomiting in the last 24 hours.
Wow.
That's 50%. So again, think collapse, vomiting within 24 hours, pericardial effusion should be on your radar for sure.
I see some of your former mentors there from Tufts on that paper.
Absolutely. This is a lovely study out of Tufts.
Yeah. So I got to say, though, sometimes, though, especially on the medicine side, I see the not acute ones. I see the subacute to chronic. So for instance, I had a golden that came in for 2 weeks of progressive abdominal distension. And that patient had pericardial effusion as its primary problem.
Yeah, so the subacute to chronics can come in with non-specific signs, photographers of weakness, exercise intolerance, maybe some cachexia, muscle wasting, decreased activity. So absolutely, we can see different variations depending on whether it's an acute cause that compresses the heart versus a subacute cause that they adjust to. And then we're going to see more right-sided heart failure signs and less specific signs.
So Dr. Boysen, these signs are pathognomonic.
All right. No, these are very non-specific and non-sensitive. As you can imagine, you could probably come up with 100 or more differentials for vomiting.
10,000.
You could come up with a lot of things for muscle wasting, not specific or sensitive.
All right. Okay. So, well, let's think about it. Again, these patients, when they come in, those triage acute cases, you know, one of the classic things we talk about, right, is they might have muffled to absent heart sounds. What else are we going to notice?
All right. And then we're going to go through pulsus paradoxus. This one's really interesting. These are the situations they come in, it's in shock, it's laying there, it looks unstable. You put your fingers on the femoral pulse and you're trying to palpate that pulse. Yep. And you're like, oh, I found it. No, I don't hear it. Wait, it's there. No, it's not there. Oh. It's waxing and waning. And you're like, oh, I found it. You start to adjust your fingers. All of a sudden it comes back. And then you realize it's getting stronger and weaker with the respiratory cycle, getting weaker on inspiration with the respiratory cycle.
Yeah.
That is almost pathognomonic for pericardial effusion. Unfortunately, it is not that sensitive. So it's very specific, but we don't see it in all of our patients with pericardial effusion.
Oh, I got you. Okay. These pictures are in black and white. Is that when you're in vet school in the 1960s? You took them? I've never seen black and white pictures for a long time. So I got to say, though, something else that we will see is pale mucous membranes.
Yes. And again, this was present in our patient. This is a sign of decreased perfusion. So hypotension, tachycardia, low temperature, all things that we saw, pale mucous membranes, prolonged capillary time. These are all signs of non-specific decreased perfusion to the tissues or shock. So again, you could probably come up with a number of different causes for shock.
So tell me a little more about tamponade. What are some of the clinical signs more related to that? Is that the cardiovascular shock?
Exactly. So in this situation, we talk about tamponade, and we talk about diagnosing it with ultrasound. We'll come back to that. But to me, as an ER doctor on the floor in the trenches, patient comes in, I see that he's got pericardial effusion, he's cardiovascularly unstable.
Yes.
That to me is tamponade until proven otherwise. So the cardiovascular signs of shock in a patient with pericardial effusion, I'm going to have that tamponade, regardless of what I actually see on ultrasound, as one of my top differentials. But we're going to come back to the cases that we can actually confirm a tamponade diagnosis with ultrasound.
So, but I look at the signs of cardiovascular shock. I mean, I could see this with a whole bunch of different things. So am I taking this as not specific or sensitive either?
That is correct. I could name at least 20 different causes of shock, and I could give you patients that might have occult forms of decreased perfusion that don't show the actual signs of shock. So again, lots of different variation there. So not specific or sensitive.
All right. Well, let's take those subacute cases. I mean, the kind of cases I see, right? And I'm like, oh, darn it. What am I seeing here? Unfortunately, a lot of those patients aren't going to have any signs of right-sided heart failure.
Yeah, so a number of them won't, split 50-50. So you could have taken either way. You could have said a number of them will or a number of them won't, because it's split 50-50 down the middle, if you look at the research that's out there. So what do we see with signs of heart failure then? We're looking for that case that you said that you saw, a couple weeks of abdominal tension. 50% of cases with right-sided heart failure will have abdominal fluid present.
But then sometimes they're going to have pleural effusion, which, depending on how much there is, that could potentially lead us to some clinical signs.
Exactly. And the problem with this is, I'll ask the question, how sensitive do you think you are at picking up a fluid in the abdomen or in the pleural space without the assistance of imaging?
Very poor.
Exactly. So again, these are signs that we will see, but they're, again, not overly sensitive or specific, and they are difficult to pick up.
Well, it's funny because I had students on that rotation. And I was like, well, you know what? Every patient we're putting the probe on, and they came running to me. It's like, we have abdominal effusion in this patient. I'm like, no, sure enough. That's exactly it. Now, something else that I think both you and I were taught in school is something else that you can see on a physical exam sometimes when you have right-sided heart failure changes. What is that?
Yeah, so just like you get a backup of fluid into the abdomen called ascites, we can get a backup of fluid in the jugular vein. You'll see this jugular pulse that radiates or causes essentially the jugular vein more than a half to the third of the way up the neck. And you see that nicely here without even holding. You'll see the pulse even while putting pressure on because of that increased backflow. And then take your finger away, you can still see that pulse radiating 2/3 of the way up this dog's neck. This patient has what we should suspect is increased right-sided heart failure.
That's definitely a situation I would stop everything I'm doing and come to find you, because you know that I'm going to be a little worried here. But again, am I hearing from you that none of these things really are like pathognomonic specifically?
Correct. So these are all things we use. These are all clues that tie pieces of the puzzle together and give us a feeling of how our patient's doing in general. But when it comes to diagnosing pericardial effusion, these are non-specific or sensitive.
All right.
Well, do you guys still teach the fluid wave? Do your students and learners still have to do the fluid wave in patients for the abdomen ascension? Yeah.
Not so much, to be honest. I mean, in cows, they do for sure, the palpable fluid wave. But in small animals, we've kind of moved away from that.
And that's probably because we don't find it that sensitive at being able to pick it up. Or we see that a patient comes in that's got a distended abdomen, he's got an underlying Cushing's or something, and we're creating waves that aren't even there. So I do find that one's a very, very challenging diagnosis to make. So I tend not to teach them. Others that are better at detecting fluid waves may still include it, but it's definitely not something that I teach students.
And actually, Oron, is distended jugular something you see in humans with pericardial effusion?
Yes. Yeah, we're supposed to look for it, but I'm often too busy looking at the screen of my ultrasound machine to focus on some of the clinical findings. So it's like the same thing with the abdominal wave. You know, I'm like, well, I'm going to fuss when I can just put the probe on and like yes or no. It's quick and easy. So
you're right, and that's exactly what we focus on as well, right?
Yep.
And although ECGs, though, they get a fair bit of ECG training at our school. I remember once Dr. Boysen was on sabbatical and I had to teach ECG. Do you remember how you taught me how to teach them?
I do indeed. I drew it on a napkin for you and said, everything you need to know is on this napkin, Dr. Chalhoub.
No, joking aside, this was true. I still have the napkin on my wall. So that's how I recognize this, right? That pattern that you're talking about here.
Yes. So ECGs, they can tell us something that's directly going to be treated. So we do ECGs both for diagnosis and response to therapy to see how the patient's responding to what we're doing.
Yeah.
So this is a good one. And you can see that this is electrical ultrasounds. It is almost, but not quite, pathognomonic for pericardial effusion.
Right. And as we saw in Shira, low blood pressure, right? Again, that potentially goes towards the shock.
So another sign. And if you think back to those causes in dogs, part of our minimum emergency database. If you get a history, dog comes in, he comes in collapsed, you got muffled heart sounds, you're thinking, ooh, this patient could have pericardial effusion, and the owner says he got into warfarin or potential rodenticide toxicity, then you're going to want to add the PTPTT on your diagnostic minimum emergency database just to see if you do in fact have a coagulopathy.
All right. So as unfortunately everything else, we have some things that are sensitive but not specific, not sensitive. The electrical alternans, that is specific, but not all cases are going to have that.
Correct.
Okay. And blood pressure, yeah, you can have varying blood pressure and a lot of different things. So I got to tell you, let's get right to the punch. We're talking about radiographs, right? Radiographs are the best to diagnose pericardial effusion. We should take a radiograph in all those unstable patients.
So back in the day, before we were allowed to touch an ultrasound machine as ER doctors or as criticalists, if we weren't a radiologist or a cardiologist, we weren't allowed to touch an ultrasound machine. And if you were in general practice, you didn't get taught ultrasound. So you did make the diagnosis on your physical exam and often with radiographs. But how good are radiographs? This is a nice study by one of our colleagues, Etienne Cote, out of the Atlantic Veterinary College on the east coast of Canada. Thoracic radiograph findings for dogs with cardiac tamponade attributable to pericardial effusion.
Well, I got to think about this. If I'm thinking pericardial effusion, that means that cardiac silhouette should be enlarged. I'm assuming it's going to be at least 70% of the time it's going to be enlarged.
An interesting finding here, 22%. So you overestimated it. Did not have an enlarged cardiac silhouette. So 1 in 5. And this isn't just pericardial effusion. This is pericardial effusion with tamponade. So these patients are coming in with evidence of tamponade on the physical exam and on ultrasound. And 22%, more than 1 in 5, no enlarged cardiac silhouette.
Okay, what about that globoid appearance? I remember in school, the globoid appearance. I'm assuming that almost all of them had it.
So, well, given that the globoid appearance is an extension of the fluid and an enlarged cardiac silhouette, it's going to be worse than the previous diagnostic accuracy. So we are taught that, though, that globoid basketball appearance. And if you see it, boom, that's classic. You should be thinking this is either going to be pericardial effusion and or severe dilated cardiomyopathy. But 42% of our dogs did not have that globoid appearance on cardiac silhouette.
All right, hold on.
It's almost half.
Vertebral heart score. VHS. The first time I learned about VHS, I thought it was that cassette we put in the thing, but clearly not. So VHS has to be more sensitive.
So it's good. We use that a lot in our cats and dogs to tell if we've got cardiac silhouette enlargement. But you can imagine if you're not going to see an enlargement on a cardiac silhouette in 1 in 5, your sensitivity and specificity is also going to be inaccurate when it comes to the vertebral heart score at detecting that pericardial effusion, 77.6 and 47.8% respectively.
Wow. Okay. So all of this indicates that radiographs aren't necessarily specific or even sensitive for detecting pericardial effusion.
No, there are other advantages to taking the radiographs. And when you're thinking about the causes in our canine patients, neoplasia, whether it's a heart-based tumor or hemangiosarcoma, we may find that the radiographs, when we take those, don't necessarily pick up the cardiac silhouette enlargement, but they may pick up pulmonary metastasis, which was reported in a third of the cases. A third of the cases. So this is, again, something where radiographs will be helpful.
All right. Well, I think we've exhausted all the possibilities. What is our go-to test?
All right. Given the topic is pericardial effusion, we're talking about the use of point-of-care ultrasound. Why don't we put a probe on this patient and have a look? What are the windows and how are we going to look for that, my friend?
Well, there are actually 3 different windows to look for pericardial effusion. I think most people assume the only window is going to be that transthoracic right parasternal, so essentially looking right over the heart, which actually is, for us, not our favorite site. It's not that intuitive sometimes.
No, it can be challenging. And the reality is there's lots of different ways you can assess the heart through the chest or from other windows. But the 3 key ones we look for specifically with pericardial effusion are the one, like you said, right parasternal, probably our least favorite. One of our favorites, the pericardiodiaphragmatic window. This is the subxiphoid window. We're coming in on midline right behind that subxiphoid. And we're picking up that heart there.
Yeah. And then the third one, likely our favorite, which is going to be the subxiphoid view. What? Finding the heart through the abdomen? Absolutely. And we're going to show that. So let's go ahead and start with our demonstrations.
All right. So we're going to show a clip of the right parasternal short axis.
Yeah. So I'll go ahead and talk about this one. So here we have the heart in mushroom. So we can see the probe is a 45-degree angle to the body and parallel to the table there. So we can see our left ventricle, right ventricle. Boom. I've swept up the heart and I'm starting to see fish mouth and then fan the probe a little bit and I get my LAAO. Why am I doing this when I'm looking for pericardial effusion? Because I want to make sure that I can identify all my structures of the heart so I don't mistake anything for pericardial effusion, for instance, or not pericardial effusion?
100% agree with you. You got to know your normal anatomy, because if you're really confident when you can find the mushroom, the left ventricle, you can see the outflow, the right ventricle and the outflow tracts, and you can see the area in the left atrium. You know what that looks like, and you've extended your depth to see that within the entire window. Anytime you put pathology around that heart, you're going to know it's pathology and not mistake it for chamber. So let's just go through that normal anatomy on that right parasternal short axis in a little bit more detail.
Yeah, absolutely. So we have a cat radiograph here. We're going to superimpose a heart over here with the 4 main chambers of the heart, the 4 chambers of the heart, and we're going to start sweeping up the heart. And we like to start at the apex. What are we cutting through right there?
So if you look at the schematic superimposed over the radiograph, we can see that when we go through the heart, we're only getting that left ventricle right at the apex.
Yeah.
And in this situation, you're only going to get 1 lumen and 1 wall. And this is a very confusing area to look at if you're not aware of it. And that's why we encourage you to look for this in your normal patients. This is the apex of the left ventricle. We're going to come back and show you why that can be a concern when we add pathology.
Yeah.
This is why you got to get your normal anatomy under control.
Got to get comfortable sweeping up and down the heart. And as you're sweeping up, you start seeing the 2 main chambers there, the ventricles, left ventricle, right ventricle, boom, until you get to where you see the papillary muscles really well, and you get to that mushroom view, left ventricle, right ventricle.
Yeah, so on the schematic, you can see we're cutting through the papillary muscles. That gives us that classic left ventricular mushroom shape and that outlining right ventricular crescent-shaped moon.
Yeah.
And that is a very classic window that we're going to assess and evaluate.
All right, so we keep banding a little more up in the heart, Dr. Boysen, until we get to one of our favorite views. I mean, visually, it's just a nice view. We get to where we see the mitral valves flapping there. What do we make our students do at this point?
Because this looks like, it really does look like a codfish or a fish with an open mouth. This is where we do the blah, 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 blah. This is our fish mouth view. This is that mitral valve. This is a key window, because just below that, if you fan back down towards the sternum, you're going to get that perfect mushroom view for volume status and contractility. And if you fan just above our fish mouth, then you're going to hit the Mercedes and the whale, whale driving the Mercedes.
Correct. And that is where you want to assess that left atrium compared to that aorta. So you get your LAAO. And again, for today's talk, not necessarily the goal, but you got to know these chambers in the anatomy, because if not, you might mistaken something for something else. Should we demonstrate that?
Correct. Let's take a look then and say, well, if you get to know your normal anatomy, what does it look like when you drop fluid around that, for example, with pericardial effusion?
One thing we did forget to mention, you go down to mushroom, rotate the probe 90 degrees, and you get that 4 chamber. Again, another way to assess the heart. And by the way, the white around the heart is the
pericardium.
Exactly. So that's what we're assessing. All right. So now let's talk about pericardial effusion. If we put some fluid around the heart, what does that look like?
So here it is. Know your normal anatomy. As soon as you put fluid around the heart, then we're going to get abnormal. So we look at this. You can tell this is done by us. We got a rib going right smack through the middle of the heart, but that's okay, because I can see that mushroom. I can see the left ventricle. I can see the crescent-shaped right ventricle around it.
Yeah.
And when I see that, I know that that's my ventricle. That's my right ventricle. That's abnormal. Even then we get up, aorta, left atrium, outflow tract, abnormal. So know your normal, and that will allow you, based on what you're looking at, to say this additional blackness around the heart is pericardial effusion. It's abnormal.
But if you're uncomfortable, remember, sweep up and down the heart. Go look for that pericardial effusion, in the same, obviously in the heart, but at different locations on the heart. And here we are at the apex of the heart. Now, this is why we say it's important to know the heart anatomy.
Exactly, because when you're looking at it down here, you can see that left ventricle. It looks like it's just a single lumen and a wall.
Yep.
If you put pericardial effusion around that, you could easily say, if that's the only window, you pop the probe on and look at it real quick, you'd say, well, that's left ventricle, that's right ventricle. I don't have disease here.
Yep.
That's why we encourage you to make sure you walk up and down the heart in that short axis, because as soon as you fan up or sweep up from that apex, you'll see the mushroom, you'll see the right ventricle, and then you'll say, whoa, that's actually pericardial effusion that I had down at that apex of the left ventricle.
Right. So that is very important, Dr. Boysen, to do, because if not, you can really confuse things, right? And miss pericardial effusion. So let's talk about site number 2, shall we? So what was site number 2?
So site number 2, that's our pericardial diaphragmatic window. And the easiest way to get this, there's lots of different ways you can find it. We like to start with the probe over the chest, about half to 2/3 the way up the thorax, with the probe marker towards the head, with the probe perpendicular. We're then going to slide the probe caudally, intercostal space at a time, following that bat sign in the pleural line. And we encourage you to look at one of our other podcasts to see what that entails.
Yeah.
We're going to slide back until we get to the curtain sign. Basically, we're looking for that vertical edge that you can see right here that tells us we're transitioning from lung into the abdomen. So that's our curtain sign. Once we see that curtain sign, we know we've hit the caudal border. We can follow that curtain sign down ventrally until we can put the heart and the diaphragm in the same window.
Yeah.
So basically, we drop back, find that caudal border, trace that caudal border ventrally until it comes in contact with the heart. That's called the pericardial diaphragmatic window because we got the heart and the diaphragm in the same window, and you can see that here.
So cool.
And that is what we're looking for when we do our pericardial diaphragmatic window. And you can see the heart curving to the left here.
Yeah.
You can see the liver and the diaphragm curving to the right.
Yeah.
And we get that little triangle of mediastinal fat between the apex of the heart and the diaphragm. And you see that in the schematic image here as well. This is a beautiful spot for us to identify because it makes it very easy to detect fluid in general. It's sensitive, and it also differentiates pleural and pericardial because pleural effusion will track along the diaphragm and it will fill this costophrenic recess.
Yep.
So it tracks the diaphragm, fills that costophrenic recess. Whereas with pericardial, it tracks away from the diaphragm and around the heart when it's pericardial.
Yeah, absolutely great site and very easy to get to. Like you said, you went cranial border, caudal ventral border, and boom. So here we go. Here's another live image here with identification, mediastinal triangle for MT. We've got the heart on the left, diaphragm on the right, and the liver, and we can see the schematic down there, and boom. Now, I got to say, Dr. Boysen, when we look at this, I'm assuming that the majority of effusion here is going to be pleural because it's tracking up and down the diaphragm.
Exactly. And that's why we really like this view here, because it actually, if you get fluid in the pleural space and you're transthoracic at this window, fills this costophrenic recess. So this is predominantly pleural effusion because it would be very difficult to pull the pericardial sac away and put it into that costophrenic recess. Beautiful spot, pleural effusion. And if it's pericardial, what's it look like?
Well, that one does have a little bit of pericardial effusion, but it's not that obvious. But if you put a lot of pericardial effusion, what do you get? Well, there you go. Now you can see your left ventricle, right ventricle, and boom, fluid around, right, being contained by that pericardial sac. So that's really what we're going to
Correct. And the nice thing here is that you still maintain that mediastinal triangle and you don't get anechoic fluid filling that costophrenic recess.
Yeah,
so
exactly.
This stays soft tissue and doesn't become anechoic and black. The black goes away from the diaphragm around the heart. Exactly.
All right. Well, let's go to our favorite site to look for pericardial effusion, and that's going to be the subxiphoid. So subxiphoid, we are going to examine in both long axis and in short axis. So here we go. You got to palpate that subxiphoid force. Very important. That's probably the most common mistake people make is they don't put the probe in the subxiphoid. You palpate that subxiphoid, and there we go. We're initially at 45-degree angle to the body, and we can see the liver, the white diaphragm. We see a little bit of the gallbladder there, and boom, we see that cardiac blend when we're fanning a little more to the right side. And there it is. We can see the cardiac blend with the diaphragm and the liver, which immediately rules out clinically significant pericardial effusion. So that is very important. You can do that patient lateral. You can do that in patient in sternal standing. It doesn't matter. It is really easy peasy to be able to see it this way. And immediately, Dr. Boysen rules it out.
Yeah, patient comes in, collapsed, shock, put the probe on at the subxiphoid, regardless of patient position, angle head, see the heart, see that it's blending soft tissue to soft tissue. You need to go looking for a different cause of shock because it's not pericardial effusion.
Yeah. So why does that work specifically in dogs? Because actually the heart doesn't touch much in cats. Why does this work in dogs? Why does the apex do this?
So if you think about an x-ray, you can imagine where the heart contacts the diaphragm, it's down near the apex. And I would say 95% of our canine patients, you'll get that left ventricle in contact with the diaphragm when you're putting the probe on at the subxiphoid.
Gotcha.
So we get a beautiful view,
beautiful
window through the liver where we can see the heart blending soft tissue to soft tissue with the liver and diaphragm. So it's a really nice way to assess and rule out rapidly, as you can see in the bottom left, pericardial effusion. This heart muscle is contracting and blending with the liver.
Right.
This is normal.
Yeah.
This is a long axis view.
Yeah. And you also want to get a short axis view. So that also helps potentially to, again, double up, the potential things that you might see. So here we go. The probe is in short axis, and there it is right there with the probe rotated. And we have our little Clarius app on our cell phone there, really quickly being able to determine if there's pericardial effusion, yes or no.
Exactly. And then if we get pericardial effusion, what's it look like? How does it contrast compared to that soft tissue to soft tissue interface? Well, on the image down here on the bottom right, you see this video down here, look at that black anechoic fluid that surrounds the apex of the heart, curves away from the diaphragm, separates and causes us to lose that soft tissue to soft tissue interface, giving us a soft tissue to fluid to soft tissue interface. This is a classic place to identify pericardial effusion. Beautiful spot to identify.
Yeah, absolutely. Beautiful spot there, Dr. Wood. Look at that heart dancing in there, right?
A little Valentine's music dancing away.
Well, I mean, Valentine's music. I mean, I see you breakdancing. That's what I see there. You don't think so? Look.
No.
No? You took breakdancing classes. I remember you.
I didn't take classes. I did.
Oh, you did?
I was
really?
part of a breakdance group, but that was a long time ago.
Breakdance group?
Yeah. Moving on.
Oh my.
Subxiphoid. Pleural versus pericardial. Also a beautiful spot to differentiate it. On the left here, you can see when we've got a large amount of pleural effusion, it tracks the diaphragm and outlines it completely. As opposed to on the right here, when we get pericardial effusion, you can see through the liver, the diaphragm, it curves away from the diaphragm around the apex of the heart. So it's really nice when you get that subxiphoid, you focus into the apex and you'll see the black curve around it and away from the diaphragm, as opposed to tracking along it when we got pleural effusion. Awesome spot to differentiate the two as well.
And that patient actually on the right also has some abdominal effusion. Look at that liver being separated from the diaphragm. Another hint potentially that could be a sign again of pericardial effusion, right? That's one of the things.
So right-sided heart failure. We talked about ascites when we talked about it earlier. So absolutely, we can see that secondary right-sided heart failure. So this is the difference between pleural and pericardial. Very nice.
So I think you have a quiz for me here, Dr. Boysen.
All right, let's see. Since I can't ask the audience necessarily, let's ask you a question here. What do you think? Is this pleural or pericardial in this particular patient that comes in and we put a probe on the chest here? What site are we looking at?
Well, we are at the PD window. I'm pretty sure about that. And I'm seeing the heart on the left. I'm seeing the diaphragm on the right. And I'm pretty sure fluid is mainly tracking up and down the diaphragm. I got to say this is pleural, Dr. Boysen.
I would agree. You can see it filling that costophrenic recess. That is pleural effusion. So again, that's our pericardial diaphragmatic window, the PD window. We slid down on the lung right there. We can see that the heart and the diaphragm in the same window, and we see that effusion there, and it's in that costophrenic recess. That's pleural effusion.
All right. So I think you have another quiz for me. I think you're trying to be different.
All right. Let's do another one here. What do you think? Real quick. Patient, shock, unstable, pericardial effusion, yes or no?
No.
Good answer. Phew. And there you see the heart superimposed. There's that left ventricular. Do I need to see the entire heart? Do I need to see all the chambers when I'm at the subxiphoid view?
Nope. That's it, Dr. Boysen. And I got to say, that's it. That's all. But again, we have a problem when it comes to cats. What is it?
So if you look at feline radiographs, you can see that a number of our cats, unlike our canine colleagues, we have a separation of the heart from the diaphragm by air-filled lung. And you can't see through air. Air is an enemy of ultrasound. So if you put the probe on this particular cat that we see the x-ray on, the fact that the heart does not touch the diaphragm, you are not going to see the heart via the subxiphoid view in our feline patients.
I tell you.
So just be aware of that. Some cats you can see it, some you can't. It's probably not you. It's not your sonographic skill. It might just be that cat, because cats are
aliens from outer space. This is true. Google tells you it is. It is true. I'm 100% sure of it. So that is a problem with cats. However, cats that have pericardial effusion tend to have what disease, Dr. Boysen?
So they tend to have cardiomyopathy. They tend to have an enlargement of the heart, which will then press up against the diaphragm and allow us to see the heart via the subxiphoid when our feline patients present with either pericardial effusion or underlying cardiomyopathy.
Exactly. And one of the biggest causes of pericardial effusion is that HCM. So that is important. So here we go, Dr. Boysen, quiz here for you. I got to ask you this time.
All right, I'm looking. This is a tough one. I got two cases here. I can see the heart. I can see the mushroom view on the left with the right ventricle outlining it. And I see black around it. Now I'm wondering, is that pleural or is that pericardial that I'm seeing on the left? And I got a similar situation. It's actually a cat here on the right. And I'm looking at this one here and I'm thinking, this is looking interesting. It looks like he's got a
fish foreign body.
It looks like he's got a very small left ventricular lumen, a very thickened left ventricular free wall. So I'm thinking, hey, this could be an HCM cat.
Yeah.
I see pericardial effusion. You told me that in our HCM cats. So is this pleural pericardial on the right?
Let's slide down. Let's slide to the pericardial diaphragm window. Sometimes it's that easy, right? And we might be able to see it very quickly, right? And we can see if fluid curves around the heart or up and down the diaphragm. So let's go ahead and do that. Or two cases. Well, whoa, look at that. I mean, that is definitely a floating fish in that chest there on the left, but I got to say that's likely probably pleural effusion here.
Not probably, definitively. Look at it, track diaphragm and fill in that costophrenic recess. If you have any doubts, and it can be a challenge when you're sitting right over the heart, just come back, find that diaphragm. Does it curve around the diaphragm and fill the costophrenic recess? It does. It's pleural versus curves away. It's pericardial. And that was the same situation in that other case that I showed you. Both those cases on the previous slide were pleural effusions.
Gotcha. So all you had to do was really slide to the PD window and boom, that's where you get to it. Okay. So what are other findings that we could see with pericardial effusion?
So there are some other things. You're thinking about is right-sided hydrostatic pressure increases. What happens when we increase that? Well, we get a distension. It backs up behind the heart. We can see that in the vena cava. So the vena cava tends to get very, very distended and it loses that cardiac pulse. So you see two images here via that subxiphoid window. You can see that we've got the liver and the gallbladder, which is normal. And we see a very narrow bouncing caudal vena cava with a pulse to it on the left.
Massive.
And the one on the right, whoa, look at how distended that caudal vena cava is. It doesn't change at all with the respirations. It has no bounce to it. This tells me that we probably have increased right-sided heart pressure, so right atrial pressure. Pericardial effusion is a big cause of that. Other things we can see as well.
So you can see hepatic vein distension. That's a big one, right? We can see that on the images on the right there. And of course, gallbladder wall
edema, which causes a halo sign. So we get thickening of the gallbladder wall, and not just thickening, we get thickening that causes it to go white, black, white in its striation because it gets edema in the wall that shows up as black, separating the two surfaces. So we get that black, white, black, white, black, white striation or halo sign.
So there's other findings that we could see, but they're a little less specific. What are they?
So we talked about this earlier. 50% of patients with pericardial effusion will have signs of right-sided heart failure. And we look for that. We talked about a fluid wave. Good luck palpating a fluid wave. What's a nice way to go after it? Let's just put that probe on there, like Oren said, and go after that abdominal effusion. Beautiful way to find it. There it is, abdominal effusion.
So much easier. Other things you can see, of course, is pleural effusion, which is kind of cool because, again, if you're at that PD window, you could probably see it immediately as well.
So you can pick up both things, one window within seconds. I agree.
Absolutely. So, okay, Dr. Boysen, we've confirmed pericardial effusion. What about tamponade? Is that something, first of all, that I should spend hours and hours trying to diagnose on ultrasound? Like, oh yeah, look, oh wait, I'm not sure. Oh yeah, no.
If your patient's unstable and it's got effusion, assume that the effusion is causing or contributing to the instability and tap the patient as a general rule. But if you have the time and you see this when you're checking and you diagnose pericardial effusion, look at this patient here on the left. Look at that right ventricular free wall and atrium. It's all wobbly and non-synchronized. It's all waving and flopping around.
That's crazy.
This to me here, this is a very good description that was actually made or provided by Oren the other day when we were talking. It looks like a trampoline. It's called the trampoline sign.
The what?
Trampoline.
It's the trampoline sign.
Oh, you added the little man.
Oh my goodness. Are you kidding me? Did you really have to put the kidney in there again?
I just wanted to emphasize that. And you wanted the kidney. You said it's not about kidney. So I'm showing the kidney jumping on that heart like a trampoline. We can see it in long axis, like you see here, the right atrium collapsing and that right ventricular free wall. It's a little bit harder here, but look, it's coming down. You get that same trampoline sign on that right ventricle wall in short axis as well.
Pretty rare. You make me laugh, Dr. Boysen. That was pretty funny. I got
the kidney in there for you.
So from what I understand, there's also rare causes of significant pleural effusion causing tamponade. Man.
So we think of tamponade as pericardial effusion, pericardial effusion, pericardial effusion. It is by far the most common cause. It's almost pathognomonic. But like I said, there are a few cases in the canine literature where you'll see that tamponade secondary to pleural effusion in the absence of pericardial effusion. So sometimes that can trick us, but it's pretty rare.
So Shira's been in the back cage for about an hour now, and we have noticed the tamponade. What should we do?
So if we see that tamponade, what we need to do then is we need to try and stabilize our patients. One of the things we'll talk about, this is pretty controversial, so we'll just throw it there real quick. We see that tamponade. We know our patient's in cardiovascular shock. It's a filling problem. It's a diastolic filling problem. So while we're getting stuff ready to tap, what we can do is we can give an IV bolus of isotonic crystalloids. So we can give an isotonic crystalloid bolus, 20 ml per kilogram, 15 to 20 mils per kilogram over 10 minutes, may help stabilize that patient while we're preparing for pericardicentesis. It's not going to save the patient.
No.
But it might stabilize it.
100%.
You gotta tap. If it's unstable, you gotta tap or it will die.
100%. And I was trained too, the same way as you, is to give a fluid bolus. But again, it's not something you do in isolation, right? So you got to tap ASAP. I think that is very important. Most instances you want to tap. We're going to talk about instances where you don't want to, right? But you definitely want to do that.
If it's unstable. So some people will make the argument, well, it's easier if you actually get it to a cardiologist or somebody to look for a heart-based mass or an underlying problem. Not if it's unstable. It's better to have it alive and not know that it is to be dead and say, you found the problem. So maybe easier to identify mass with fluid in the pericardial space, but don't compromise your patient's safety. If he's unstable, you got to tap him.
Yeah.
Even small residual pericardial effusion
100%.
will allow you to see that as masses in many situations. And you can often stabilize them significantly by even removing a part of and not necessarily all of that fluid. So you got to stabilize them. That takes the priority.
Yeah, 100%. And again, chances are that fluid's going to reaccumulate to some degree anyways, right? So that's very important. But there are situations where tapping can make the patient worse. Now, again, when we've talked about the causes, the main causes, we're talking about pericardial effusion because of neoplasia or idiopathic. That's definitely something you need to tap. But what else?
So in that situation, we've got that patient that's got Coumadin, he's got coagulopathy, pericardial space is filled. We're going to transfuse those guys and tap them. We usually give them a plasma transfusion very, very quickly.
Yeah.
So bolus 10 mils per kg over 10 minutes to try and get those clotting factors on board, then tap them, then give the remaining amount of that plasma over the next 2 hours.
Right.
The other situation, in addition to coagulopathies, would be a situation of a left atrial tear.
Yeah. So that is concerning. I mean, that's essentially a blood clot in there. Is that what I'm seeing?
Yeah, and it's very rare. We see actually a clot in the pericardial space.
Yeah.
But we will see it with left atrial tear. Some of those little small breed dogs that have those large left atriums and mitral regurgitation, etc., they'll actually tear the left atrium. In that situation, we can see that clot. So we're trained to think it's anechoic fluid in the pericardial space. Just be aware there can be a few exceptions. Left atrial tear with a sudden clot or a tear because of trauma and a clot might not show up as anechoic fluid. And if you look at the patient here, how would you know that it's a left atrial tear? Well, one, it's usually going to be an atypical breed, a smaller breed, as opposed to our large breed dogs that are more classic for pericardial effusion. And look at that LAAO. Look at that left atrial to aortic ratio. If it's a left atrial tear, that left atrium is going to be significantly enlarged, as opposed to most of our pericardial effusion cases that aren't due to left atrial tear. They've got a normal or even a hypovolemic left atrial aortic ratio.
Yeah. So, but of course, the situation, if that patient's in tamponade, you need to tap him immediately, which obviously is potentially not, going to be a good thing that's going to happen there. But, again, it's a very poor prognosis in that situation.
Yeah. So hopefully they come in, their heart rate's a little bit elevated, they're collapsed, but got back up. You look at them, they're not in the process of dying. You check it. It's got a pericardial effusion that you see a clot in, left atrial enlargement. You may be able to treat them conservatively. But if you have to tap them, you have to tap them. Yeah.
So let's talk about tapping. Again, something very important you need to do. Most of the time, we do give them a sedative, right? So nothing too heavy, right? Because of course, especially those unstable dogs, right? So that's going to be important. We either do it external or in lateral recumbency, right? Whatever preferences for the operator, that's going to be very important. And sometimes we will do a local anesthetic.
And an ultrasound-assisted guided procedure. So we check to see where the pericardial effusion is, the widest, biggest pocket. We see what the angle is with our probe, and we either ultrasound guide it in, or we remove the probe and use the same angle where that probe was. And we'll walk in usually with a 14-gauge 5-inch IV catheter, with or without extra fenestrations on the side to allow better drainage. You can see this is one of our patients that came in. We got him on a little bit of supplemental oxygen. You see the ultrasound machine right there because we used it to diagnose, and we're going to check him again here in a minute. We've got the needle in the pericardial space, and we're removing what looks like blood. We do have them on an ECG to watch for arrhythmias as we do this procedure. Because you can tickle the heart. And that's why we have that lidocaine prepared and drawn up.
Tickle the heart? That doesn't sound like a fun tickle. Just saying, tickle is usually a funny thing.
Yeah, most people don't like tickling in general, whether it's the heart or other.
So again, in cats, most of the time, we're not going to tap them, right? So again, that's pretty rare. I've never actually had to tap a cat in 15 years. I don't know about you, but pretty rare.
Yeah, so we only do the cats when we see evidence of tamponade. Either they're in shock or we see that ultrasound. Otherwise, we don't. It's incidental. We rarely tap them. I agree.
So what else can we do? I've heard some people place indwelling pericardial catheters. What?
Yeah, you mentioned that fluid is likely to recur in the pericardial space to allow us to do better ultrasound. 29% of dogs reportedly have recurrent bleeding. And in that case, do you want to keep sticking a needle through and tapping them?
Yeah.
Not necessarily. So what's another option that we've started to look at? These are mylar chest tubes that we can put in, small bore guide wire chest tubes. Yeah. And this is a bit of work that they do in the UK. You can see that this video particularly here was compliments of Bert Jan out of Sweden.
Yeah.
But the research has been done out of the UK, and you can actually put your catheter in, drain the pericardial space, then use a Seldinger technique. You can feed the wire in through that catheter to use to tap it.
Yes.
Remove that catheter, leaving the wire in the pericardial space, and then feed that chest tube, which is fenestrated. It's a nice chest tube to leave in, because you can then slide that over that wire. Make sure the wire isn't stuck in that pericardial space. Make sure it's out of the catheter before you feed the catheter in.
Right.
You don't want to leave that catheter in the pericardial space. And then we can actually fix that catheter in after we remove the guide wire like you see here, and we'll suture that in place. And now you've got a nice catheter in that pericardial space. Should the patient have a recurrence, you can just simply drain it from that catheter. If the patient's doing well, 24, 36 hours later, there's no more fluid accumulating, you can just remove the catheter. Very cool. So a couple of studies that have been done in the UK, you can read those if you like. They're listed here if you're interested in that, but it is something that we're starting to do in our patients.
Okay, very cool. So let's wrap things up. When we talk about prognosis, right? Unfortunately, it could be 100% mortality, right? If the clinical signs are pretty severe, especially when that pericardial effusion is not removed promptly, right? That's a big deal.
Yes. And then our prognosis in general, if it's a tumor, if it's hemangiosarcoma or one of those heart-based tumors, there's a bit of variation in the longevity, but median survival for the hemangiosarcoma, it is guarded at 1 to 4 months. The heart-based tumors, we're probably looking with pericardectomy 730 days, without pericardectomy 42 days. So that pericardiectomy does tend to have a beneficial effect in the heart-based tumors that are growing slowly, because it allows that fluid to accumulate in the pleural space. It's a less life-threatening area that can be absorbed as opposed to the life-threatening pericardial space. Yeah, and idiopathic, well, again, if it's truly idiopathic, some reports of like up to 4 years of living. So in summary, cats, again, develop pericardial effusion, but usually non-clinical, usually secondary to HCM. Correct. Dogs require pericardiocentesis most often due to tumors and idiopathic causes. We got to get them as stable as we can as quickly as possible. Yeah. Confirm that pericardial effusion, multiple windows using point-of-care ultrasound. We've already talked about 3. Yeah. And make sure that depth's extended so you can see that pericardium when you're assessing them, especially on that right parasternal view, but in all windows. And then, as we said, pericardiocentesis can be performed. And I will encourage you that we've 100%. Got a few models out there. This is something that you can do as non-specialists. You don't have to be a cardiologist. You don't have to be a specialist to tap the pericardial space. And if you do get comfortable capping the pericardial space, think about that small bore indwelling pericardial catheter for recurrent drainage without having to do repeated taps. Yeah. And as we talked about, prognosis varies with the underlying case. And on that, that is the end of our discussion, point of care ultrasound for pericardial effusion. All right. Thank you for joining us. We'll turn things back over to our hosts.
Thanks so much, guys, for that very entertaining and informative presentation. Please keep using the Q&A. We're probably going to go a little over time, and we'll get to it at the top of the hour. So if you can stick around for a few extra minutes, we'll get to the Q&A. But before we get there, we're going to hand it over to Shelley Gunther, our clinical marketing manager, for a quick demo.
I have my dog Mabel here, and Mabel is going to show us her little heart.
Hi, Mabel. We're not going to see a pericardial effusion today on Mabel, I don't think.
No, hopefully. No, she's pretty good. I did have a pre-scan of her, so
it's going to be a beautiful heart with a lovely left atrial ratio.
Beautiful, yeah.
I can feel it.
I'm going to just scan her in the upright position here, which I have learned from you gentlemen. I didn't think that was possible, you know, being kind of in my set in my ways as an ultrasound tech, but just scanning underneath her right arm, and if I go all the way. All the way down to the apex here.
Yeah.
And then upper rib space.
I think I saw a fish at one point, and we're going to ask you to do your best fish impersonation.
All right. There we go.
Oh, you got it. There it is.
There it is. And then all the way back up to the aorta here. Aorta. And we can see that there is no pericardial effusion around here in Mabel. So she's
nice.
Good to see another day at the dog park for sure.
Nice. Awesome. Great. Quick and easy. Love it. Okay. And then please keep using Q&A. We're going to hand it over to Janez here.
Thank you, Dr. Frankel, and thank you, Shelley, for the beautiful live scanning, and Mabel and Drs. Boysen and Chalhoub for all of your best practices. A friendly reminder to stay on for at least 50 minutes to qualify for 1 CE CPD credit. Before we begin our live Q&A, and we hope you'll stay with us at the top of the hour, we have a question for you. This poll is an opportunity to learn about our 3rd generation Claris wireless ultrasound scanners for your veterinary practice, which are now available in over 90 countries. Please complete this poll to let us know if we can provide you further information about Claris vet scanners. Do click on as many options as apply. Pricing and availability does vary by region, so please request a quote and pricing, and we will do that in your local currency. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss scanner features, please select that option. You can also book a one-on-one virtual demo with one of our clinical experts to see the new Claris in action introduction and a very interactive one-on-one demo session. And we can send you more video tutorials for veterinary medicine. So please go ahead and select as many options as you wish. While you take a minute to complete the poll, I'd like to tell you about our Clarius Vet HD3 scanners for the highest definition wireless ultrasound imaging to speed diagnosis for small, medium, and large animals. Our C7 HD3 microconvex vet scanner, which you saw in action today, is specifically designed for clear clinical imaging for small and medium animals like cats and dogs. We also have the C3 convex vet for larger animals like sheep and horses, and the L7 linear vet for superior animal MSK imaging, often used in equine applications. Now, 30% smaller and lighter, more affordable with an enclosed battery, our third generation family of vet scanners are unrivaled for high resolution imaging in a handheld ultrasound system with dedicated animal presets. Clarius shows you the fine details you need to investigate an area of concern, perform a fast exam, and make a confident diagnosis on your patient's first visit, expedite the right treatment plan. Each scanner is designed with not 1 or 2, but 8 beamformers and 198 elements that deliver the image quality and speed only found in compact systems, but at a fraction of the cost, representing 85% savings. Artificial intelligence replaces complex knobs and buttons to optimize imaging and streamline workflows, making our scanners fast and easy to learn and use. Clarius is also wireless with zero footprint for high portability to scan animals where they are. You get free movement with no wires getting in the way or startling the animals, also making it easier and faster to clean and disinfect. Only Clarius wireless scanners come with an ecosystem that includes a free app for your iOS and Android devices with free updates. Available with our new membership, Clarius Cloud is used to save and manage unlimited exams and create reports anywhere. Your membership includes in-app Clarius classroom videos with experts like Dr. Chalhoub and Boysen, as well as onboarding with Clarius clinician to build your ultrasound scanning skills. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. Your membership also includes the popular Advanced Veterinary package, which offers more flexibility and additional tools and advanced workflows for various animal examinations, for example, with finely tuned presets categorized by anatomy. For veterinarians who prefer a one-time purchase over a membership, the Advanced Veterinary package is also available as an add-on. With increased ultrasound billings, you'll see a rapid return on your Clarius Vet HD3 scanner, which is ultra affordable. We'll now take 3 seconds to close out the poll so that you can request more information. 2, 1. Thank you for participating. We will get back to you in the coming week. We have one final poll prior to our Q&A session. We'd like to invite you back on May 9th for more learnings with the dynamic duo Drs. Boysen and Chalhoub. Please click yes in this poll to pre-register and save your seat for our next webinar, Veterinary POCUS, Renal Pelvic Dilation. It's not the kidney's fault. I'll give you 5 more seconds to save your seat. 4, 3, 2, 1. Fabulous. Let's now begin our live Q&A session. Please use the questions icon in the menu bar to ask your questions for Drs. Boysen and Chalhoub. And because this is a common question, I do want to let everyone know that in the coming days, we'll send you an email with the recording for today's webinar, and you will receive a link from the Vet Show to redeem your CECPD credit. I'd like to welcome back Dr. Frankel to moderate our live Q&A session.
All right, great. Thanks for sticking around, everyone. We'll try and squeeze out as many questions as we can, maybe in about the next 7 to 8 minutes here, respecting your time. So I'm going to just start firing away to you guys, Surgeon Cern. So maybe first question is, this comes up every time, do you use gel for your ultrasounding, or are you using something else? Alcohol, shaving, what are you doing?
Alcohol, rarely shaving, especially for that initial diagnosis, right? Of course, if you're getting ready to tap, then you shave, you do a sterile prep. Still using alcohol though, because that gel will get in the way. But yeah, we're using alcohol most of the time. If I have a patient that's not pericardial effusion, I'm trying to assess LAAO. So let's say a Yorkie, high heart murmur, I'm looking for mitral valve regurgitation. Sometimes it will add a bit of gel because it does give me sometimes a nicer view of the heart, but if not, it's always alcohol.
Yeah, if you go back and watch this video again when it's available, you can see that the demos when we scan those dogs to show you the windows, that was done without shaving and with using alcohol, no gel. Mm-hmm. Just make sure you separate the fur so you can see the skin, because the goal behind clipping is to be able to remove the fur. And if you can part the fur and see the skin, it's the same essential image quality most of the time as you get with clipping.
Yeah.
Great. And then where do you, a lot of people want to know kind of what side do you approach for the tap if you are going to tap them?
Excellent question. We almost always come in off the right side.
Yes.
It's the right cardiac notch. The window where there's no lung is larger on the right side, and we have less risk of hitting the coronary vessels on the right side. So we always pretty much come in on the right side. The one thing I will say, though, is nowadays, as opposed to what we used to do 15, 20 years ago, we'll assess the largest pocket of pericardial effusion with ultrasound to help us guide the exact site that we should go in at on that right side. But we always do it on the right side. So we usually put them in left lateral, sternal, or if you have a cardiac table, you can put them over a cutout window so that you can come up on the right side in that right notch and maximize your fluid accumulation with gravity to tap that.
Yeah.
Yeah, that's how we do it in humans too. These days, most of us will just look for the biggest pocket because it's the safest place to go.
Yeah, exactly.
What kind of sedative do you use? Is there kind of a standard, or are you just sort of making it, deciding on the case?
So it depends. Often we'll use butorphanol, usually 0.4 mg per kg if we need to, just because it really just takes the edge off. If we need to give something more, sometimes we will.
Yeah, and if we need a bit more analgesia in there, then I'll go with a pure opioid. So I'll go with fentanyl, or I'll go with hydromorphone, or one of the pure opioids. But usually it is in the opioid family for sure. It's rare we have to go with anything else.
Yeah, exactly.
What do you do? A lot of people want to know, what do you do when there's pleural and pericardial effusion? How do you tell?
Good question. I mean, chances are the pericardial effusion is probably the cause of that patient's being unstable. I mean, obviously, if it's a ton of pleural effusion, but chances are I'd probably tap the pericardial first.
Yeah, so just to be able to tell that they're both there, that's that pericardial diaphragmatic window.
Yeah.
If you'll actually see the fluid curving around the diaphragm and filling that claustrophrenic recess, but you'll also then see a white line that curves away from the diaphragm as well and around the heart. So we can see that pericardial and pleural effusion. Very easy to diagnose both conditions at that pericardial diaphragmatic window or at that subxiphoid window. A very easy spot to get them both. And actually in that situation, you'll usually go through the pleural fluid to hit that pericardial space. You'll end up draining a bit of that pleural effusion in the process.
Yeah.
If they're in respiratory distress, then that pleural effusion does need to be addressed as well.
Yeah. I mean, if they're in tamponade, you tap the pericardial effusion, chances are things will also start to re-equilibrate, right? That's another thing as well. So yeah, I tend to focus on that pericardial first. And someone asked about the probe. We tend to use the microconvex, right? I mean, we tend to use that probe pretty much for everything.
Yep.
Yeah, in my trainees, when I'm teaching point of care ultrasound, we always offer an award to whoever can find the abdominal fluid, pleural effusion, and pericardial effusion all in a single window, and it's usually subxiphoid right there.
Nice.
We actually have a beautiful clip of that as well. We didn't put it in the talk today, but we do have that tricavitary effusion.
Tricavitary, there you go. Yeah, gets you a six-pack. That's right. What do you misdiagnose? I think you brought up one slide, but we were going pretty fast at the end. Like, where do you kind of make mistakes on diagnosing pericardial effusion? Like, what can you kind of incorrectly think is a pericardial effusion or not a pericardial effusion when in fact there is one?
Yeah, when you're looking at the heart straight on. So when you're transthoracic, looking at the heart straight on, and you're way down at the apex of the heart, where essentially you're just cutting that left ventricle, which means you're just seeing in a normal patient, they'd be just that left ventricle. If there's pericardial effusion around that, you might mistaken that for the left ventricle, right ventricle view. So apologies if that was confusing, but that's why it's important to scan or sweep up and down the heart to then properly see that left ventricle, right ventricle view with fluid around it and be identify the normal structures of the heart.
And include other windows as well. If you're not sure, include the subxiphoid and the pericardial diaphragmatic window. And the other thing I'll say is make sure your depth's extended. Although I haven't seen it myself personally, I do understand if you're not extending your depth far enough and seeing the far wall of the heart and the pericardial sac, then you can mistaken chambers of the heart for pericardial effusion as well. I have heard of people that have tapped chambers of the heart by mistake, thinking it's pericardial effusion. So again, that is not something you want to do. So make sure you extend that depth and see all of the heart and the pericardial sac in your window.
Yeah, exactly.
Yeah, if you start seeing blood come out, second guess yourself maybe. Yeah. You showed also that the clot, the right atrial rupture when there's clot. I feel like that's common false negative. You see it, you might think it's organ and not identify that it's pericardial effusion too, right?
Yeah.
Yes, exactly. When you've got that clot that shows up as a soft tissue structure in the pericardial space, a lot of people won't see it because they're so tricked into thinking I got to see black anechoic, that's pericardial. You can actually see it as a soft tissue opacity, very isoechoic in appearance when it's a clot. So yeah, absolutely 100% agree with you, Oren. Very good point.
Yeah, 100%. And someone asked, I mean, the concerns with the catheter, but also with tapping, when Cern was talking about tickling the heart. I mean, yeah, you can't see arrhythmias, and most of the time you're going to see ventricular premature contractions.
Or ventricular tachycardia. It's really irritated. And that's why we have that lidocaine ready to infuse.
Yeah.
So I will obviously watch for that when I put the indwelling catheters in.
Yeah.
But we usually find that if you're going to get the VVCs, it's usually during the initial insertion of the stylet, that metal contact with the myocardium that's going to cause that arrhythmia, as opposed to just the soft catheter that's in the pericardial space. Possibility, but we don't tend to see it that frequently. So again, I would encourage you to read the literature out of the UK on that specific, because they do cover some of the complications in there as well with that procedure.
And I just saw a question, Oran, about the subxiphoid view and the size of dog. There's no doubt large dogs, it could be quite hard to see the normal heart blending into the diaphragm. Although I would argue if that dog has pericardial effusion, chances are you will probably see that a little bit more. But yeah, there's no doubt large dogs, deep chested dogs can be more challenging, which is why we use 3 windows.
And the windows are better, yeah. Great. I want to respect everyone's time because we're 10 minutes over. So thanks so much. If we didn't get to your question, we will certainly be following up in the days coming. And we want to thank to our hosts and to all of our guests from all over the world.
Yes, thank you very much for joining us on Valentine's. Hopefully you have a good evening, day, or morning, depending where you're joining us from.
Hope your company is better than mine for Valentine's.
And we hope you had as much fun as we did. We hope to see you all again on May 9th. For our next POCUS webinar on diagnosing renal pelvic dilation. In the meantime, please keep scanning, and we wish you all a happy Valentine's Day. Thanks for joining us.
Thanks, everybody.
Until next time.